Soft tissue sarcomas and bone sarcomas are essentially rare diseases that often require expert opinion. As such, I think that patients with a diagnosis of a soft tissue sarcoma or a bone sarcoma should be referred to an expert sarcoma center early in their disease course, so that way we can help the clinician maximize their patient's chance of having a better quality of life as well as hopefully a better survival. I usually recommend that when the patient's diagnosed that they reach out to our center. I think most sarcoma centers in America have different or unique mechanisms to help draw in patients early. I think this is important because oftentimes there's a lag time between the time a patient experiences symptoms to the time they actually have a diagnosis of sarcoma. And this can sometimes impact their own quality of life or their survival. Once a patient comes to see us in our center, we typically will ask the patient to spend several days with us so that way we can order appropriate testing and also sometimes seek expert opinion from some of our consultants, such as our surgeons, our pathologists, our radiation oncologists. Oftentimes we'll discuss the patient's case in the context of a sarcoma multidisciplinary conference where individuals that only specialize in sarcoma will sit down and review the patient's individual case, and then we'll try to formulate the best possible plan of care that we can have for that particular patient. And then it's really up to my responsibility to contact the referring physician to let them know what our recommendations are. Typically this may involve a telephone call, but because sometimes our schedules may not always coincide, at least secure messaging that's HIPAA compliant is recommended, so that way we ensure that the patient's not going to have any loss of care as a result of recommendations that aren't met.
More often than not, the primary care system will get their local community oncology team involved, whether it's a surgeon for a localized mass versus a medical oncologist for something that's widely metastatic. And this is the point where it can get a little tricky. I think the reality or day-to-day practice is that the patient's anxious, patient wants some answers real quick, the medical team wants to help them out, so they will do the best they can. That is, that oncologist will then consult with their radiologist, get a biopsy done, tissue ends up with the local pathologist at that community hospital who takes the first crack at it, if you will, consults with some referral pathologists to try to confirm the diagnosis or at least confirm the subtype. And at that stage, maybe the referral happens or maybe the oncology team is comfortable enough, feels comfortable enough to treat the patient locally within the system, community system. Where should an academic center get involved? And the ideal scenario would be the earlier the better. And that's self-fulfilling a prophecy, and I understand that. But the healthcare systems that have made the most difference are the small nationalized healthcare systems. There's a healthcare system in Sweden, for example, where any soft tissue mass that's 5 centimeters or greater gets referred into the local university in Lund, and no community or private oncologist or private physician will deal with it. That's not practical in a country like this with facilities available all around. So I think my recommendation clearly would be that as soon as a suspicion of sarcoma is entertained, maybe refer the patient at that time. If that's not practical because patient cannot travel, insurance won't cover, whatever the reasons, then clearly the local team is going to do the very best they can to establish the diagnosis, but at least a phone consult at that time to their regional local academic center to say, here are the details that I'm dealing with. What should I do next? And more often than not, when I get a phone call like that, I will say, what you say and what you have in front of you makes sense. And here are things that you can do in the local area, and keep me posted, and I'm happy to help as you go along the course. Or I may say, well, what you have just does not make sense. If the patient really can come, I would much rather you send the patient over. Let us take a look at things, formulate a plan in the appropriate way with multidisciplinary input, and then we can get back to you and kind of have a shared management plan where if the patient needed systemic chemotherapy, we would send them back with recommendations that they could get in the community. They will get 2 cycles, for example, come back for scans so that we can stay involved in the management of the patient and help guide the therapy, versus there are instances wherein we are happy making the recommendation, but the phone has to ring in my office for me to be able to help. And I think that's the key thing. And when does that happen? It tends to vary in different circumstances. And again, to a certain extent, it's up to the comfort level of the local team as to how comfortable or not comfortable they are dealing with the diagnosis and the treatment.